Good afternoon, everybody, and welcome back to Grand Rounds. Today, it is my pleasure actually to reintroduce Alicia Mercado. Alicia was actually here last week, and she gave us a really nice overview of the demographics and the diagnosis and the treatment of syphilis in Iowa. She works for the Iowa Department of Public Health in the Bureau of HIV, STI, and Hepatitis, and has very kindly accepted our invitation to return today to provide us with an overview of HIV in Iowa. And please join me in welcoming Alicia Mercado. Thanks.
Thank you, everyone. I am going to do a little bit more than just HIV. I will add some gonorrhea and chlamydia and hepatitis C in there for you, if we can get through it all in the time frame. So I am on my own today. Neither Maria nor Annie could come. They had more and more cases of STIs that they needed to follow up with. So thanks for having me back. I am a regional health equity specialist, specifically in my title. My focus is health equity. And so if anyone is interested in more specific work or information around that, I'm happy to be your contact. So speaking of equity, let's get started just by reviewing the HHS Office of Equity. Here's their principle, their vision, and their mission. As we serve the communities, we like to remember the Office of HHS Office of Equity's guiding principle, vision, and mission. The overarching vision is to build health equity for all communities, not just the physical towns that we live in, but also the communities and people that live inside our towns. Many of the people most vulnerable to HIV face stigma, prejudice, and discrimination in their daily lives. This pushes them to the margins of society where poverty and fear make accessing healthcare and HIV services really difficult. And so if we can work together to decrease stigma, then we will be welcoming and be a safer environment for people who feel stigmatized and marginalized to receive the care that they need. One of those ways that we can help reduce stigma is talk about language. We can change our language, very simple, easy ways. And so here, I'm going to have 2 slides about the stigmatizing language, and then the preferred language is in the middle, and then a brief description of why we would ask that you use the preferred language. So one example is if you talk about somebody battling HIV or AIDS or the war against HIV and AIDS, those are kind of stigmatizing words. We would like you to use the words response to HIV and AIDS. The stigmatizing words can be very militaristic and lead others to think about people living with HIV have fought or are being eliminated. And so we want people to really think of it as what we're trying to do is respond to people or to the virus and improve services and medicine for people living with HIV. Here's another chart with stigmatizing on the left and preferred language on the right. Let's see. So if anyone says there's an AIDS test or they want an AIDS test or you hear people talking about an AIDS test, we would encourage you to just politely model preferred language. It's actually an HIV test that you can offer them. When we talk about someone being compliant, that's kind of has a negative tone to it. Let's try to use the word adherent. So are they adherent to the medical recommendations? Are they taking their meds adherent to how the doctor prescribed? If you're compliant or non-compliant, it's just more negative. And so the last one I'll go over is saying tainted blood or dirty needles or dirty blood. So we would like you to say blood containing HIV or shared needles or used needles instead of the dirty and the tainted words. We do have disparities in healthcare, and so if we can start by changing our language to reduce stigma, we can also help the disparities that we see. And so on the left pie chart, you will see the population of Iowa by ethnicity and race. You can see the red portion is people who identify as white. The people who identify as black is in the dark blue pie, it's just 4%. And then the 6% is people who identify as Hispanic in Iowa. And then the pie chart on the right is going to show you the Iowans diagnosed with HIV by ethnicity and race in 2021. And so you can see that 51% of the people diagnosed with HIV are white, 24% are black, and 16% are Hispanic. So you can see there's big health disparities. If there weren't, then those two pie charts would look the same as far as the number of people diagnosed with HIV being the same as the population breakdown. So there's a national strategy to address HIV. The first one is to diagnose as early as possible, and we want to link people to HIV testing. So if you work in a clinic that doesn't do it, or you hear people talking about it just in your everyday life outside of work, be prepared to offer suggestions on where people can go to get tested. The second pillar is to treat. We want to treat HIV as quickly and effectively as possible, which also means linking them to HIV treatment as fast as possible. And then prevention. We want to prevent new HIV transmissions. We want to link people to get services like PrEP prescribed, or behavioral health services, where they can also get access to PrEP and mental health counseling and referrals to case management services if needed. And then we want to respond quickly to the clusters of new cases. And so people like Annie and Maria, who you met last week, they're the disease intervention specialists. They're the ones that respond to the clusters and try to get people connected to services as fast as possible. So STIs increase the likelihood of HIV acquisition. If we're going to end HIV, we also need to address STIs. Co-infections of HIV and other STIs is increasingly common. Here is the pie chart that shows this. So out of everyone diagnosed with HIV, 8.2% were also diagnosed with chlamydia. And you can see the other percentages there. And this only notes the people who were actually tested and screened for other STIs at the same time or within 30 days after their HIV diagnosis. This is what HIV looks like in Iowa. In 2022, 27% of the people diagnosed with HIV were living in rural counties. So we are one of the few states that has the largest percentage in our rural communities. And then 30% are in Polk County, as you can see. Excuse me, I have a tickle in my throat. I'm trying to get through here. And then the other red counties are other urban areas where 43% of the people diagnosed with HIV are living. Every year, Iowa puts out a care continuum. And so this is our care continuum that we used in 2022. These numbers are based off of everyone diagnosed with HIV in 2021. Okay, so through statistical data and analysis, they believe there was around 3,569 people living with HIV in Iowa, but only 3,105 were actually diagnosed. That is improved numbers. We used to be at 14% of undiagnosed people living with HIV, but now we're at 13%. And then 89% of those people diagnosed were linked to care within 1 month. The goal is get them in care within 30 days. And then 84% of people diagnosed were retained in care, and 80% were virally suppressed. Iowa has the highest percentage of viral suppression. So this is a very, very good number. Across the United States, the viral suppression rates are closer to 65%. So a little bit on viral suppression and U equals U. If you're in the room, can you raise your hand if you've heard about U equals U? Have you heard that term before or that? Okay, excellent. So U equals U means undetectable equals untransmittable. And so on the left, you see a little picture of what it might look like in a test tube with HIV. Before using antiretroviral therapy. And then after somebody is on their meds, ideally the HIV level will decrease in their blood. And so if their viral load is at 20 or below, then they are considered undetectable, which means they can't transmit HIV through sexual behaviors through unprotected sex. Does that make sense? And so undetectable is untransmittable. And then viral suppression. The goals of HIV treatment are to improve the health and prevent transmission of HIV. The best marker of successful treatment is reducing the amount of HIV in the blood and elsewhere in the body to very low levels. This is called viral suppression. 3 different studies of the prevention effectiveness of viral suppression to reduce the risk for sexual HIV transmission have shown similar results. Across thousands of couples and many thousand acts of sex without a condom or PrEP, no HIV transmissions were observed when the HIV positive person was virally suppressed. This means that getting and staying virally suppressed is not only the best thing people living with HIV can do to maintain their health, but it's also one of the best ways to prevent new infections through sex. So a lot of people don't understand this. And when I was a case manager for 4 years before this role that I'm in now, I was able to tell people about U equals U and this viral suppression. And just to see the weight lifted off people's shoulders, knowing that they could not transmit it because they are virally suppressed and they are undetectable was just very healing and helpful for them. And so not a lot of people understand this, and so if this comes up in conversation, I would also encourage you to talk about that. Or if you need more information, there is a local case manager in town that would be able to help you, or I can, obviously help you with helping others understand that. So I talked about being a case manager. Federal funds have provided for Ryan White Part B and Part C services. Part B services provide many of these assistance for people living with HIV. All services are free and confidential. Typically, case managers receive referrals through health departments, through doctors' offices, through people who are moving in the area and know that there are services around and they are trying to enroll in services because they were in them where they used to live. The goal for these services is to help people be able to focus on their medical needs and put a priority toward their medical needs so they can go to the doctor when requested, when needed, and get their medicine so they can take it daily and work toward viral suppression or undetectable. And so these, as you can see, these services take away many of the barriers that people might face. This will show you about viral suppression and the impact that case management has on it. On the left, you can see people in case management, 88% were virally suppressed. And then on the right, only 67% of people not in case management are virally suppressed. And so research has proven that case management has a good impact on viral suppression. So if you know somebody, or if, meet someone in clinic who is living with HIV, you can ask them if they have a case manager, if they're interested in hearing about those services, and then you can tell them from this previous slide some of the support that can be offered for them. When talking about health disparities earlier on, I wanted to show you this slide. It is showing the benefits of Ryan White's still case management. So on the left you have African, and on the right you have Latino. And so you can see in the lighter columns, those are the viral suppression rates for people in case management. And so the viral suppression rates you see are much higher also for Latinos and African, US-born or foreign-born people living with HIV. And this is a map of where the services are spread across Iowa. Here for Ames, you have a satellite site from the Des Moines agency. And so the closest in Des Moines is primary health care. And so they can provide both the medical specialists for people living with HIV and case management. And then Sunny is the name of the case manager up here in Ames to help. The other HIV specialists are in Davenport, Iowa City, Omaha, and Sioux City. And then of course, there are doctors across the state that are infectious disease specialists, and so some of them will also serve as specialists for people living with HIV. So we're going to talk about screening. Here are the recommendations. CDC recommends that everyone between the ages of 18 and 64 get an HIV test at least once in their lifetime. In general, people with the risk factors over on the right in those circles should get tested more frequently. Pregnant women should be screened for HIV, and including those who have not received prenatal care. And so if you meet somebody who is delivering and has not received prenatal care, it would be smart to do an HIV test for them also. And so the CDC recommends men who have sex with men, persons who inject drugs or their partner injects drugs, people who test positive for STIs, people who exchange sex for drugs, or people who have sex without a condom or PrEP also get tested more frequently for HIV. And now we'll move into statistics. So in 2021, there were 124 new diagnoses in the state of Iowa of people living with HIV. That's a 96 out of every 100,000 prevalence rate. In 2022, that number is 122 people were diagnosed with HIV. Here is the trend over the course from 2011 to 2021. And so pretty level, some ups and downs, but we just continue on. And this is the trends as far as people diagnosed with HIV and then people who have an AIDS diagnosis, and you can see that has been going up slightly over the last several years, but deaths among people living with HIV is decreasing. And so services, medicine is definitely improving and helping people live longer, healthy lives. Males outpace females 4-to-1. As you look over the last 10 years, that's typically what we see, males being the majority of people living with HIV. People aged 25 through 44 years continue to account for the largest proportion, which is 53% of people diagnosed with HIV. Diagnosis in this age group increased by 28% between 2020 and 2021 after a slight decreased by 2% from 19 to 2020. Youth and adults age 15 through 24 years experienced a significant decrease in new HIV diagnosis from 2020 to 2021 by 31% after having a sustained increase in diagnosis over 2 years in a row. Rates by mode of exposure have changed significantly since 2020 to 2021 also. HIV diagnosis increased overall in all modes of exposure categories. Most mode of exposure categories increased by 5 to 8%, but you can see there's a steep increase in people whose mode of exposure is heterosexual, which is a 78% increase. This increase in people with heterosexual mode of exposure aligns with similar increases among non-US born people who mostly report heterosexual mode of exposure as their primary risk. And this is HIV diagnosis among foreign-born people living with HIV, similar to pre-COVID trends. 29 of the 124 people diagnosed with HIV were not born in the United States. This is an increase of 7% from 2020. And now we're going to move into some STI screening information. This is specifically for gonorrhea and chlamydia in women. So women sexually active women younger than 25 should be screened annually regardless of signs or symptoms. Women older than 25 with the following risks should also be screened annually if at increased risk. If they have multiple or new sex partners, if one of their sex partners had an STI, if they have signs and symptoms of the infection, and all of these others that are listed here. And then for men, men who are a part of populations with high burden of disease. So sexually active gay men or other men who have sex with men should be screened annually, and including extragenital sites like in their throat and the rectal area. Young men in high prevalence clinical settings should be screened annually, like adolescent health clinics, STI clinics, and corrections. Who here works in a clinic where you also do extragenital testing? Excellent. Very good. We do find that a lot of clinics don't do the extragenital testing, and so remembering to ask what kind of sex they have, where they have sex on their body, what type of sex, will help you understand what kind of testing you should do as far as oral testing, anal testing. So quick with syphilis, I know we talked a lot about this last week, but pregnant women should be screened at the first prenatal visit and retesting early in the third trimester and then at delivery. And then women at an increased chance of acquisition. For example, if they have signs or symptoms during pregnancy or the partner was diagnosed with an STI. And then for men, for syphilis, it's similar. So sexually active gay men or other men who have sex with men should be screened annually. More often if they're at an increased acquisition rate, maybe every 3 to 6 months. STI screening recommendations for pregnant women. All women under 25 and older women with an increased chance of acquisition. Retest during the third trimester for women under 25 or at increased chance of acquisition, and test of cure for chlamydia infection 3 to 4 weeks after treatment. We're going to go into stats about STIs. And so this is Story County chlamydia. Way at the bottom, you can see that the county rate for chlamydia for 2022 was 537 or 534 cases. Your population in the county is 99,472. So the state rate you can see on the left side is 14,633. And then Story County for gonorrhea, it shows that Story County had 67 cases last year. And then across the state was 4,466. You can find these heat maps and get these numbers off of a website, for the STI Department of the Public Health Department STI website. Sorry, I'm not explaining it very well. I can show someone afterwards if you do want to see. It's public information. You just click on the county and it pops up these numbers for you. So for syphilis, we just showed trends. And so you can see the trend over the years of the increasing numbers of syphilis. This is all stage syphilis. This is what the trends look like for chlamydia between 2016 and 2020. So you can see it was rising and then it did dip down for 2020. We are waiting for updated slides. I'm sorry, these are a bit outdated. And here's the trends for gonorrhea. This one did not dip down. It has continued to rise. And this data is from community-based screening services here in Iowa. So the positivity rates for chlamydia is highest among adolescents. Gonorrhea positivity rates are highest among those 25 and over. And this is the trend for syphilis. It just continues to go up, like gonorrhea. This is spread out again for race and ethnicity. And so if you look at the same color of bar, blue, the dark blue is the 2020 numbers, 2019 is the yellow, and down toward the left. So you can see the highest rates of diagnosis are among people who identify as white. And then you have Black and then Hispanic after that. I wanted to go over this slide one more time because I didn't have the notes to talk about why it's important to test for syphilis to a pregnant woman at the 28 weeks and at the end. Potentially, also with the rise in numbers, that we had 11 cases in 2021 that were not averted, and then we had 8 in 2022 that were not averted. Potentially, somebody didn't have any prenatal care before they delivered, so there was no testing before, so it would be important to test at birth. Maybe there wasn't adequate treatment for syphilis if she did have a positive result early in pregnancy. And so also potentially somebody is moving from facility to facility and now you are their new provider and you don't have much information from the facility where they were at. It would be a good idea to test again. There could also be other social determinants of health, other barriers that didn't, like transportation or concerns with housing or insurance problems, financial situations that led them to not be able to complete their testing or complete their treatment or even get prenatal care during some parts of their pregnancy. I thought I hid this slide, but anyway, it's some signs and symptoms of gonorrhea and chlamydia. Most common, there aren't any, but also the vaginal charge and burning sensation. But also if there are other serious sequelae, infections can be very serious, particularly in women, lead to ectopic pregnancies, chronic pelvic pain, infertility. So if you see somebody with those symptoms, you could potentially think about STIs also. This is a reminder that there are treatment guidelines from the CDC and multiple different ways that you can download them on in an app, and that app automatically updates. There are little booklets, there are wall posters. So if you need help accessing those, just let me know. I can get some for you. But you can also go to the CDC and get them for free through their ordering system. Services to minors, just a reminder that you may be serving minors, people under 18. State law gives you the permission to do this. I think most of you know this, but wanted to make sure, that I put this out there for you. It's important to remember as you do your work. Over 60% of our clients are 24 and younger, and a large percent are considered youth or teens. So you can serve minors without their parents' permission. And then there's expedited partner. Any adverse reactions should be reported to the disease intervention specialist, which is Annie Roderick for your county. So clinical practice of treating the sex partner of patients diagnosed with chlamydia and or gonorrhea by providing prescriptions or medications to the patient to take home to their partner without a healthcare provider first examining the partner is what EPT is. Do you guys use that or do that in your clinics? Nope. Okay. If you want to talk more about that, please let us know. Annie can definitely answer all of those questions for you. Just wanted to do a quick reminder of sexual health assessments. It's very important. Through research, we know that people are more likely to open up and talk to their provider about their sexual experiences if the provider starts the conversation. And so that's it can be uncomfortable for some people. So just so you're aware, helping start that conversation with your patient is going to be much more successful if you bring it up. And if they seem nervous and, not answering very much, just keep asking them questions. These are the 5 areas that you can start by asking questions and then kind of going on based on their answers. It's also important through your sexual health assessment to think about extragenital sites that you should be testing. Ask open-ended questions when possible instead of just yes and no. And make sure you're using understandable and non-judgmental language. Sometimes when we work in this field every day and we understand the language, we don't always use language easy enough for people who don't do this every day to understand. So just remember your terminology and slowing down some for people. So this is a slide about extragenital testing. It's important to testing for chlamydia or gonorrhea for only urine specimens misses 70 to 88% of infection in men who have sex with men. So it misses a huge amount. Rectal gonorrhea infections are asymptomatic 85% of the time, so supporting the need for routine screening. Rectal infection is linked to an increased chance of HIV acquisition. So remember that if you're doing STI testing for chlamydia, gonorrhea, some others, you can always offer to do HIV testing, syphilis testing for them also, and then have it be an opt-out test instead of wait for them to ask for the testing. So in Iowa, the provider and the laboratory are both required to report the findings. This is a quick map of the disease intervention specialists around the state. So you met Annie last week. She's Area 8. You guys are in Area 8 also. the pink salmon color. Now we're going to talk about HCV. It's recommended that baby boomers, people born between 45 and 65, are tested at least once in a lifetime for all adults over the age of 18, all pregnant women during their pregnancy, people who currently or have ever injected drugs, and then patients who test positive for HCV antibodies should receive a confirmatory CPR RNA test. And then people living with HIV, it's important to get them screened for HCV also. Also, people who have received certain clotting factor concentrates before 1987, it's important to test them. People who have received blood transfusions or blood components or an organ transplant prior to July of 92 also. HCV is the most common chronic blood-borne infection in the United States. It used to be known as non-A and non-B, and a blood test became available in 1992. It's a little bit of the history. 85% of adults with HCV will develop a chronic infection. It can be cleared spontaneously in about 15 to 25% of patients, and it can be cured. There's a 97% cure rate for most of the meds. There's often no symptoms. 80% of cases have no symptoms of HCV, and it's 10 times more infectious than HIV. It's transmitted through the blood, most often related to shared injecting equipment. Individuals newly infected with HCV are typically asymptomatic or exhibit mild clinical symptoms such as fever, fatigue, loss of appetite, some other symptoms here. Some people might not even think about HCV, nor providers might not think about it. It also could look like a cold, right? Or, some kind of virus. So something else to think about is the HCV virus. And then some statistics for you. This is kind of a heat map here. Right above Polk, the dark county is Story County, as you know. And so your numbers were 255 cases of HCV between 2000 and 2020. This is the trend across from 2000 all the way to 2020 in the diagnosis of HCV. This is the trends for people under age 40 in diagnosis for HCV. And then quickly moving on to our condom distribution efforts. If you would like free condoms for your office space, for your waiting room, for your exam rooms, there is a program through the state. I believe you probably already order through us, but if you need more information about it, just let me know. Or you can go to myiacondoms.org and get them ordered. So these are ways that you can help end the HIV epidemic after all of that information. So increase HIV testing for your clinic. Understand your important role in linking people to care. Provide referral information regarding Ryan White services. Understand that I'm here to help you. The DIS is here to help you. We can, if we don't know your answers, we'll get you to the people who can help you. And then try to help us combat the stigma related to HIV. Annie wanted me to give you this information again since she couldn't be here, to please reach out to her if you have questions about testing and treatment. And this is my slide with my information. If you're willing to do an evaluation, you can use your phone and that QR code, or I have some paper evaluations in the back. It's really short, 2 questions, but I would like to know what else we can do to help you. Anybody here in the room have questions for me? Thank you so much for having me again. And I do have my business card and a list of other education topics that I can provide if anyone is interested in doing smaller groups or having me come back to Grand Rounds for any of the other topics. So thank you so much, everyone, for your time.